It's from Kisner and Colby, okay? And then so your test will be Thursday while I'm gone. And there's just, the section Unit 11, which, yeah, I mean, there's a decent amount of information here, but literally this is basically going to function as your Canvas notes now. Okay, so unless it tells you specifically that you need to look at your Canvas notes, the one big exception here is pelvic floor. You need to look at your Canvas notes for that. We're not going to go heavy into pelvic floor. Just understand that there are PTs and PTAs that are specifically trained in pelvic floor issues. Obviously, it's mostly for women, but not always technically. And it's strengthening for after pregnancies. There are some other type issues, and when they have urinary and bowel incontinence, pelvic floor strengthening can help. There are like special programs for it, but it's not something you will just do. It's something you have to kind of go and get further training in. The main thing you need to know, and there will be a question on a test about this, is just that the best way to strengthen the pelvic floor is to do exercises where you pretend you're trying to like prevent yourself from peeing or stopping the flow of pee. Okay, they're Kegels. Yeah. But anyways, that's really about all you need to know from that. I would still read over that section just so you have a general understanding, because it's possible in time you'll want to get into that. It's also possible, although unlikely, but you might see a question or two on the boards, and so it's good to have, just a general idea of it. But it's not something I'm going to heavily emphasize, or we're going to talk to you too much about. Okay, in fact, this is it. This is all you'll get on that. Then pelvis and hip. Okay, and we'll go through specific stuff. Some of this stuff you will already know because we've already kind of talked about total hip replacement, and it should help you quite a bit with that. And then the knee, and some of these things we've actually even talked about a little bit with the knee, although the knee is a little bit more extensive just because it's one of the most common injuries that you'll see and deal with. Not just one, but like there's lots of knee stuff. And then just general basic stuff at the end there that you always need to know. Okay? All right. So we're going to switch back and forth between that today. I'm going to switch back to this real quick. So we're going to real quick go over PNF strengthening. Oops. Why is it doing that? I had it and then messed it up. There we go. PNF strengthening stuff. So one of the things to make the patients in clinic different than their outpatient exercises is to throw PNF techniques in there, not just the PNF patterns. We did go over those with Therese, but we're going to pair up and go over these again real quick, just so you guys can kind of get it one more time, kind of a review real quick. So what was the first one we talked about? Anybody remember? It's that one. What's it called? Anybody? Rhythmic initiation. Good. So rhythmic initiation. All that is basically understanding that a patient who's not able to move a part of their body or not able to move a part of their body effectively, if you have them do that action repeatedly, it will start making the connection with their brain. So what Therese showed us was somebody, we're having them reach out to try and initiate rolling, right? So at first we passively do it for them, and then we have them try to active assistively do it, and then actively do it. And then if they get far enough into it, we can start resisting them even as they do that. So that progression that we talked about from the very beginning, that really is it. You can do that with any action though. If it's just they can't, their hip, they had a stroke. Strokes are weird. Depends on where the brain was affected, where that brain lesion is, where the bleed in their brain was. They might be able to do like all the hip actions except flexion. Okay, and so just because it just damaged the part of the brain that controlled hip flexion, and so they're going to have to relearn that. So you can do the same concept just with hip flexion. Okay, so you would start them just laying in sideline, and you go, okay, we're going to practice this, and I want you to think about as I move your leg, moving it, okay, and then as they get better and progress, it's, okay, now I want you to try and help me, and then it's, okay, now I want you to do it on your own, and then it's, now we're going to resist you as you do it to start to strengthen. Okay, does that one make sense? We're not going to go over that one too much. The rest of these we're going to try though. Okay, anybody remember what the next one was?
Alternating isometrics.
Alternating isometrics. So pick a partner. And I'll demonstrate here just real quick. Okay. So alternating isometrics just means we're resisting in one direction and then in the opposite direction or in multiple other directions. So we could have, I need a volunteer. Don't matter who. No. So just sit upright to start with. So gather around so you can kind of see. So when I used alternating isometrics a lot was with trunk strengthening, which really applies to what we're doing today. You've got somebody who has gotten to the point where they can sit up, but they're not able to really do much dynamic sitting. You have them start trying to reach for something, and all of a sudden it's, okay, then you're still having to strengthen core. So this is when I would really use alternating isometrics a lot. So I want you to push forward against me. Don't let me push you back. Hold it for 10 seconds and then do the reverse. Hold it for 10 seconds, then do the reverse. Then go to the side. Then go to the other side. Okay? Then as they get better, you just kind of randomly throw it in all different kinds of directions. Doesn't need to be a specific pattern. Because what's going on is their brain's having to respond quickly, and you're making those better connections with those neural pathways, okay? It can work with anything else, so go ahead and lay down for a second. Okay, so let's say they're weak in their hip, okay? I could have them, and I could try and push out, push in. If their leg is up, I could try and go in all different directions as they're holding their leg up. So I'm strengthening all those different hip muscles as I do it. Works the same with any joint. Like if their foot was what's affected, okay, I could do the same thing. I could try and push her into dorsiflexion, plantar flexion. I could try and evert and invert. And does that make sense? So it doesn't matter where you're doing it. It's just a really good, effective, hands-on way to do strengthening. So, speaking of our practicals, this is a really good in-clinic type exercise. Okay.
Is this also going to be, I mean, the same thing for, I know we're not on balance, but balance? Is that same principle
it affects
used
balance
or not?
in a sense, in that a lot of the key to balance is trunk strength and leg strength, your base of support with that. There are perturbations in balance, but that's a little bit of a different thing. So it applies, but it's not exactly balanced. Does that make sense at all? Okay.
Could you do this to somebody like standing up to help with
Sure.
that?
Sure. If they've moved to a point where they're able to stand, but once you start standing them and they step, that's when they lose their balance. Then it's a good way to start initiating these core muscles, and you're really trying to get more of those long-term endurance muscles to fire. With balance, a lot of what's going on sometimes is they may even have those power muscle fibers, type 2 muscle fibers kicking pretty well, but their type 1 have gotten weak over time, and so they don't just have the endurance to just hold muscles in place, and so they're just kind of wobbly. So go ahead and stand up. You could do exactly the same thing in standing. I'm just going to push, 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 pull, 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 and do a similar things. It's a lot like perturbations, though, that you will learn with genital, okay? Where you literally push people, okay? So,
Is that just like initiating like the co-contraction so that both muscles are working?
well, now co-contractions is something else. So
Oh.
let's just be careful with our wording because I don't want to confuse people. These are single contractions by single groups of muscles, okay? That's what makes them different from the next one we're going to learn, or review actually, which is what? Rhythmic stabilization. Good. Rhythmic stabilization. So the key with rhythmic stabilization is it's still isometric contractions, but you are co-contracting. You're having two different muscle groups contract at the same time. So I'm going to pick on somebody else now. Who wants to be? All right. Take a seat for me. Good. So the key here is those co-contractions like we talked about. Instead of just firing isometrically one group, we're firing two. So if I pushed here and pulled here to try and turn him and had him resist, and then went the opposite direction, push and pull, okay? Well, actually I did it, sorry. Okay, you just need two firing at the same time. Same concept though, go ahead and lay down for me. Okay, so if I had him with his leg up here, okay, and I said, I want you to push down with your leg here, and I want you to keep this leg up, and I'm pushing two different directions at the same time. I'm trying to extend the knee, and I'm trying to extend the hip at the same time. It's co-contractions, okay? It just gets multiple muscles firing at the same time, okay? It's a little more complex on the brain, and that's where the PNF comes in. Instead of just getting one group of muscles to fire at the same time, we're trying to train the brain to fire multiple groups of muscles at the same time. Make sense? So, like I said, you can do it on the trunk. This is where I mostly did it, but you can use it for any other part of the body, okay? Just you want to make sure you have two groups of muscles firing at the same time. Doesn't matter. They don't have to be like opposites of each other. It doesn't have to be rotational. Some people say that. It doesn't have to be rotational. It's just two separate groups of muscles firing at the same time. Okay? All right, what's the next one?
Could that apply to just a diagonal pressure? Like say if they're just sitting here and you push them this way, like diagonally, would that be the same thing?
No, because I mean you're still, I don't know. It's the key is just two kind of separate and distinct directions.
Okay.
All right, what's the next one? What?
Slow reversals.
Slow reversals. Okay. These are also called dynamic reversals, I believe. Okay, just so you know. Slow reversals, we'll use Zapia again here. Okay. I love these for trunk strengthening. We can get on the side. So scoot down just a little bit for me. And would you lower him for me? So definitely want their feet on the ground for this if you're using it for the trunk, okay? Since we're doing trunk stuff right now anyways, but this is a really good exercise. The key is they're a lot like alternating isometrics, except they're actively contracting, okay? So I want you to push me forward, push, push, push. If you're in a chair, just let them actually push you forward. And now I want you to pull me back. Pull, 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 pull. Okay, you can do the same thing on the side, push. So push, 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 and just kind of resist them. and then push, 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 and kind of resist them. The key is that you're still contracting, you're basically contracting the opposites of each other. Okay, so go ahead and lay down for me. It would work the same way with the leg. I have him up in flexion of the hip. I want you to push down, push, 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 and now push up, push, 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 push. I'm having them do the same action of a contraction, but in opposite directions, and that's the reversal there, okay? But they're both doing concentric contractions, okay? The final one is what? Agonist reversals. Good. And so the key here, and I'll show you a couple different versions of this one, is that you're contracting the same group of muscles. Okay? So I'm working on his flexors. His flexors are weak for his abdominals. Okay? So I want you to push me back. Push, 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 push. And now I want you to continue to resist me as I try and push you back. Push, but you have to go with me. Okay? So as they're still kind of fighting you, but they are going back. And so it's getting both a concentric and an eccentric contraction. All right, lay on your back. You can do this with bridging as well, okay? So real quick, show me a bridge. Okay, good. What muscles is he really firing here? The glutes, right? Good. Okay, that might be important at some point. So if I put my hands here on his ASIS, okay, and I resisted him as he came up, and then I said, I want you to go down very slowly, and I'm going to push against you as you go, okay? He's still firing what group of muscles? The glutes, okay? Glutes both ways, okay? So for going back just a step, for the slow reversals, if I was doing it here, I would go, okay, push up, push up, push up. On the ASIS, then I reach around to the PSIS, and I have him push on the way down. What am I strengthening on the way down? Yeah, your core, more your abdominals as you try and push down. Make sense? Glutes on the way up, abdominals on the way down. Wait, one more. I didn't tell you to do that. Just kidding. Okay, so if you were doing a leg, okay, I might have him all right, I want you to push up against my hand. Push, 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 push. Okay, now I want you to slowly lower your leg and control it as I push against you. Push, 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 push. That's that agonist reversals. I'm working on just one group of muscles, but I'm reversing between a concentric and an eccentric contraction. Okay? All right, break up into pairs. Okay, I don't care too much who this time. And I want you to work through each of these. Try 2 or 3 different groups of muscles.
What did you say was it?
PNF strengthening.
PNF strengthening.
Oh, yeah.
You just need to sign this and bring it back to you.
Yes. Understand it's kind of a progression, okay? Rhythmic initiation is really the easiest form of this, of trying to make those neural connections between the brain and the body. Once they get to where they can resist, then you're moving them basically to alternating isometrics, okay? Once they're able to do one group of isometrics, then you're moving them to multi-group isometrics, then moving them to slow reversals, agonist reversals. So just kind of understand that that's the progression here. But if somebody comes into you and they're already pretty advanced, you can start at any point in this. It's not like you have to walk through the whole progression, okay? So, in your lab times, practice these, okay? I'll leave them up on the board for a while at least. So you can use these to kind of cue you. They're just a great way to do a more hands-on exercise. The more hands-on exercises you're doing, as long as they're appropriate, make the patient feel like this is something they could not do at home. Okay? And then you can use your TheraBand exercises or maybe a weight to send them home with. Right? Okay. All right. Moving on. So I've got some handouts for you. We'll start with these. Take one of those, take one down, pass it around.
So Brett, that's not saying that, like when you're in clinic, you couldn't do TheraBand with your patient. It's just saying that
It
it's.
doesn't mean that. And I don't know, part of this is just a preference by different therapists and a concern that if you limit your in-clinic exercises to something they could do at home, they're gonna quit coming, okay? So it's not that you can't do some TheraBand exercises, especially if they're really early on in the process. That may be all they can do or tolerate. But you want to make sure that you're doing enough skilled, high-level stuff that the patient feels like, I can't do this at home. And they want to keep coming. And they're getting something with you and with the clinic that they could not get at home. Does that make sense? And so it doesn't mean that you can't do isometrics. It doesn't mean that you can't do TheraBand. It doesn't mean that you can't do just some dumbbell exercises at times. It just means that as much as you can, you want to try and figure out a way to make the stuff in the clinic a little more complicated, a little more hands-on, to where they feel like they're getting something extra for the money that they're paying, instead of honestly looking up Bob and Brad on the internet and just doing their stuff on their own. Does that make sense?
That hands-on aspect is like the key.
Really, that's the key. Is that hands-on part. Does that make sense? All right. All right, so we already did a little few core strengthening exercises here, but we're going to go through and talk about core strengthening a bit. The core is just this area here and in your low back, okay? The source of a lot of back pain, and you'll see a lot of different back pain cases, is just bad core strengthening. And one of the best ways to deal with that is to obviously strengthen and stretch. Strengthen and stretch. And so I want to make sure that you guys know at least some good beginning core strengthening exercises and when to use them. I printed out this packet. This is like a really, really, really good packet from a physical therapy place. Princeton's protocol for these, and they're good. We're not going to go through them all, but they are good ones to know, but we are going to look at some of the early progressions of them. So, real quick here, let's get our, because I want to kind of go over just some different, I'm going to sneak in here and steal. Okay, one of the most common things you'll see that's a cause of back pain is pelvic tilt of one form or another. Okay, so we're getting into some of the stuff in your notes, and we'll hit on it more if we need to. So anterior pelvic tilt would be what? The top of this, and of course there's a bar through it, so I can't really do it. But this part, the bottom is pulled back, the top is pulled forward, which causes the spine to get more curve in it, right? Because these are basically connected with all these ligaments and muscles, okay? The coccyx and, well, not the coccyx. But anyways, the sacroiliac joint here, the sacrum and the ilium here, as you pull the ilium forward, the sacrum's going to come forward with it. The sacrum is attached to the lumbar vertebrae, right? They're all interconnected, and that's going to cause the spine to pull forward. So I'll draw that kind of here. So we've got this tilt, okay, which causes the spine to kind of come forward, and you get this sway back kind of action going on, okay? So that's, and you can get the opposite as well. So this is anterior pelvic tilt. You can get the opposite of that. You get the top of the ilium, and it's kind of, that's not very good, but whatever. And you get the opposite problem though. So the spine actually kind of gets flat back here and maybe even bows out a little bit. Okay, the discs in between here. And instead of getting that swayed look to it, you get it almost kind of creating this. So instead of, what is this? What curve is this? Lordosis, okay? You get a lordotic, an extra lordotic curve here. You get more of a kyphotic curve here. Does that make sense? Okay, and so these different exercises can help with these. You just need to understand what's going on. So, once again, we've talked about this before, what muscles are weak here? Abs are weak. Good. Weak abs and weak hammies. Yep. And what muscles are tight? Tight QL and tight hip flexors. Good. So, what would that mean going on over here? Just the opposite, basically. So you've got tight abs and flexor. Tight abs. Okay, and you've got tight what? Quads, right? Kind of the opposite of what we have. And we have weak QL, right? And weak hip flexors. Okay, so to deal with that, we stretch one group, strengthen the other. There is another somewhat common type of pelvic tilt, except it kind of works a little bit differently. We've got the pelvis from the side here, and something along those lines. Okay, where one side is higher and the other side is lower. Okay, it's called lateral pelvic tilt. Air conditioner finally kicking on?
No, I'm just saying that's me.
Oh, you got a little bit of lateral pelvic tilt. So what's going on here? Anybody got any ideas? Usually it's almost always just a tight QL on one side that's kind of pulling it up. Could possibly be obliques or abdominals on one side are tight as well, but usually it's a tight QL on that side. So what you'll see is as somebody walks, this side, this hip will hike, okay? And it's called hip hike, and you'll just notice, and this side kind of drops in, okay? And these, so what's going on also here is that you'll have tight and overly strong abductors here as well that are pulling that hip out and up, and then there'll be weak. The abductors will be weak on this side. Okay.
Is it like the same thing with the Trendelenburg?
It can be part of what causes actually Trendelenburg gait. Good connection. Okay, so just know that. So anyways, one of the best ways to deal with any of these really is strengthening the core. Okay, and other issues too that we'll kind of talk about and get into. Those make sense? Sorry. Didn't even follow my own advice.
So you were saying it says tight abductors on one side, and then it was loose abductor on the other?
Yeah, weak abductors on the other. Because on the side where you're up, your abductors will kind of naturally start firing more as you walk. Okay, so this is going to hike and it's going to cause that abduction as they go through, and this side is going to kind of just wobble in, and it's because this QL is tight and these are overly strong. So you would stretch these, stretch this side, strengthen this side. Okay. All right. And that's really the case with anything. Is like anytime there's an imbalance, there's strength on one side, weakness on the other. Tightness on one side, weakness on the other. Okay, so let's look through these exercises here. I'm not going to go through all the different flexibility stuff, but you can look at those. The very best ones, though, are simply these prayer cat camels, okay, where you have somebody get into that prayer pose. Let me go, okay, and they're here. Pull up my hand. So they get into a prayer pose here, and then they go up to here, and they go to a cat where they kind of extend their back, right? And then they go to a camel where they try and bow their back, okay? And you have them switch in between those. It's just a good way to stretch those different muscle groups, okay? So anyways, those are a good way to do that. But we are going to look at some of these strengthening exercises. We're going to start with this abdominal draw in, because this is the best place. So somebody who has low back pain, lumbago, anterior pelvic tilt, where they've got excessive curvature here, we want to strengthen the abs, right? So the easiest way to do that, and this one's probably a good at-home exercises, but I'll show you some good variations. So you can do it on your own. But you just have the patient think about their belly button, and you want to have them try and push their belly button down through their body and decrease the space here, right? So just think about kind of drawing that belly button down and pushing your back into the table, okay? So that's a really good at-home exercise for them to do. Same as any other 10 sets of like 2 or 3, okay? So anyways, get with a partner again, and then I'll show you guys. Let me get a volunteer here real quick. I'll show you guys some variations and ways to make that a little more complex for if you're doing it in clinic. We don't have big. Okay, so go ahead and lay down for me.
This way?
So, there's a way to kind of test and tell if they're actually engaging those core abdominal muscles and really pushing down, okay? So, if they've got an excessive amount of lordosis in that back, you might have to do this with something a little bit thicker than this, like a towel that's rolled up, or maybe even like possibly, depending on how bad it is, one of those half foam rollers, okay, to start with. So can you bridge for me? Okay, so I'm just gonna put this right underneath her. Okay, so Katie, what I want you to do is I want you to think about kind of drawing your belly button down in, and I really want you to try and push your back. Okay, and so what I want you to do is when I tell you to contract, we're gonna contract and we're gonna hold it for 3 or 4 seconds. Okay, all right, ready? Go. And I kind of pull at this. Okay, I can tell if she's contracted by if I'm able to get some here. Okay, now relax. If she relaxes, it should slide right out. Okay, but if she engages, lift up again. Okay, all right, go ahead and engage for me and hold, 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 and now relax. Okay, you can do that for 3 to even up to 10 seconds, right? And it's a really good interactive hands-on way to see if they're actually firing. Now, because she doesn't have real excessive, it's still going to strengthen those abs, but it can be pretty thin. You can do it with a gait belt too. Put your gait belt underneath them and kind of give it a pull. And you can tell when they're not and when they're relaxed. You really can. So go ahead and relax it, and you can just slide it right out. Okay? Because they should have that curve. Now, if you're doing it and they're laying on it and you can't pull it, it means they have the opposite problem, right? Okay? So we'll talk about that here in a little bit. So this is a good exercise to strengthen those abs. You can roll up a towel, or like I said, you can do the half foam roller as well, where you're getting it in. Because some people, it's so bad and so excessive that you can really tell. That you would just have them push against that, and then kind of maybe move to the towel, and then maybe move to this. Okay.
So you hold the foam roller, or you just have them push it?
I would even try and pull it just to make sure they're really engaging, because it's really hard to tell whether they're firing that, and that's a good, easy way for you to give them an indicator whether they're actually really pushing down and firing those abdominals. Does that make sense? Sure.
So when you're teaching the pelvic tilt, something to help also along with this, one of the ways your patient is going to try to cheat is by firing the hamstrings and pushing their back into the mat. Does that make sense? So go ahead and do that again. I keep a hand kind of here and just see if they're engaging that hamstring, because when somebody's super weak, especially down low in transverse abdominis, they don't know what this feels like or how to do it correctly. It takes some time to teach this. They're gonna try to cheat with their hamstrings. So it's another way, just an easy way to look. If they're pushing and they're engaging, they'll be like, nope, relax here, all right here, okay? And they're gonna struggle to breathe and hold that at the same time. So have them count out loud, so that they have to breathe and do that pelvic tilt.
What? Yes, sorry. So, okay, another one, just, that's good, and I'll have Katie stay there. For the abdominals as well, is just to have them, so lift your legs up for me, you can put a ball right underneath here, and have them, so we're still working on these abdominals, except we're getting into the obliques a little bit too. Have them come here. So you want to watch. So I want you to kind of, try and keep your hips down. Okay, so you can even hold and just have them go back and forth. Okay. If they're having a hard time keeping those abdominals engaged and keeping the pelvis down, you can just put a little pressure on those anterior superior iliac spine and have them go back and forth. The further they can go, the more they're having to kind of engage those abdominals. Okay?
You have them hold it in this position for a certain amount of time?
You can. And that's just, a hold is just a way to take what you're already doing and make it a little more complex. Okay? Add a little more strengthening to it. So if you have them go and hold it and then bring it back and hold it, that's fine. You just want to make sure you document that and say patient did 3-second holds of, the contraction. Make sense? Okay. There's a couple other ones we'll do. Okay. So just advancing this. You can still have them, and we'll just do a couple others here. So, go ahead and lay down your bridge for me. Okay? And these are just progressions of this. So, those two are pretty early stage strengthening exercises. But you can have them start doing things like, okay, I want you to keep this leg up. I want you to bring this leg down. Okay? I want you to think about, go ahead and draw that belly button down, and now slide this foot in as you do it. Okay? It's a lot harder, right?
Yeah.
Okay? And so that's a way that you can progress it, is as they get stronger, they should be able to keep that core engaged while firing these lower extremity muscles as well. So you can start with just a single slide. You can also have them just bring this one leg up and hold it and push down. Okay, she's doing better with this one. Okay, and the final way you can progress that is go ahead and lift up both legs. Okay, and now try and. Okay, you feel. It's just a way to make sure that you're really engaging these. Okay. All right. Anyways, there's further progressions in that, but these are good for strengthening abs. Okay? Alright, we're moving on though. Okay? So, if they have the opposite problem, posterior pelvic tilt, okay, I need a new volunteer. We want to then increase flexion. Okay? Extension. We were doing flexion exercises and abdominal strengthening. So on your, you actually want them on your belly, okay? So a good way to do this is just to have them start trying to, so you can do, you put your arms out for me in front of you, okay? And just have them try and kind of, so I want you to just lift up your arms and kind of curl your back. Good? So you can start out with just the upper body. These are called Supermen. Okay? Go down. And you can have them hold it. You can start with just the upper body. So just kind of start with just your arms if you can. Okay? Good. And now relax. Have them do 3 sets of 10. You can then start adding, okay, to progress it. Add here. Good. So you're firing all through that. Then you can add like opposite legs. Here and this arm, okay, and then do the other side. Good. And so these are just some ways to start strengthening those extensors. We'll look at these just a little bit more as we look at Udo. Okay. So I want you guys to group up again and go through these. Okay. Just the ones we just did. Okay. These are some simple, more beginning ones.
Because they're trying to engage rectus abdominis and not T. So when you try to engage rectus, you end up like this. And then if you do TA, you just pull up.
So if you concentrate on keeping your shoulders pinched and firing rhomboid while you try and fire that, it makes sure that's more to
So
the
you're trying to do like a posterior pelvic tilt
You can
almost.
put it back.
Your-
It's over there.
your
No.
anterior trying to go.
No.
Don't do it.
How much is there bouncing it?
All right. So we're gonna switch to Dr. Joe for just a second and watch a few QL stretches. All right, pay attention, please. Pay attention, please. We won't watch all of them.
ball. And you're just kind of rolling it through to up and over. Hey
You can
everybody,
tell
Dr. Joe and QL Remy, and today I'm going to show you my top 5 QL stretches for back pain. So let's get started. Disclaimer alert, disclaimer alert. So the first stretch, you want to get into the butterfly position. So the butterfly position is so you put your feet together out in front of you, your knees are out to the side, and depending on how much flexibility you have, you can bring your feet in. So if you have tight core muscle, this might be a little difficult, so you just get into a comfortable position. Then the side that you want to stretch, so this is my left side, I'm going to take my left hand and bring it up and over, and then take my right hand and kind of push down and through. And so I'm just going to kind of stretch this way. I should feel that stretch kind of right into here. Some people like to kind of push down on the opposite knee to get a stretch, but I personally like almost like you're taking a big ball and you're just kind of rolling it through. So you're going up and over and pushing through. And I get a really, really good stretch with that. So since it's a full stretch, you want to hold it for 30 seconds and do it 3 times. So if you just have one side that's hurting, I would still stretch both sides just because you want to keep everything balanced. And I also, if I do both sides, I like to alternate back and forth. You don't have to, you can do them all on one side and then switch. But a lot of times if you're alternating back and forth, it gives the other side a little bit of a break. So then the next stretch, you're going to take your leg that you want to stretch. So I'm just going to switch now so you can kind of, if I want to stretch my right side, I'm going to put my right leg out. And so just kind of out at an angle, maybe that 45-degree angle, or if you were going to do a split with your leg. And then so it's still kind of the same concept. So now I'm going to bring my arm up here because I want to stretch this side. And then I'm leaning over. And again, a lot of people kind of like to push down on that knee. So you can push with your arm if you have a little more flexibility, or you can just kind of push with your hand and just kind of get that stretch all the way down. So I'm feeling that stretch all the way kind of in that low side of the back, and that's where that QL or that quadratus lumborum is. And that muscle, a lot of times people forget about, but it has a lot to do with back pain. So again, 30 seconds, pushing down on that opposite knee, getting that stretch, holding it 30 seconds, doing that 3 times on each side. So you can also do kind of a little bit of a change modification with this one. So you're still in the same position where you got one knee bent and the other one out. And so this time when you come up, you're going to rotate your whole body over to really get that extra stretch. So I'm bringing my arm up and I'm turning my body almost like I'm pointing over to the opposite side. So arm up, rotate over, bring down. I'm really getting that nice big stretch through there. And so even though it's kind of hard to do, you can just do a small stretch if that's not too hard. Then you can come back up and then go back over a little bit. So you can modify it a little bit. And even if you just kind of turn without going down, you might feel a little bit of stretch with that. 30 seconds, 3 times on each side. So the next stretch is going to get you in a little bit of a tougher position. So if you have other,
We're gonna stop there because those are some pretty good starting ones. Okay. You can actually take those and vary them just a little bit. You know, there are ways to vary those, but like if you're wanting to do them with a patient in the clinic, stabilize, okay, on one side, push on the upper side. So stabilize along that iliac crest, and then push up here along the trunk to increase the stretch if they're having them do it. And you can even have them, just like with hold relax or contract relax, either come back towards you and then stretch it more, or just push against you for those autogenic. I want to make sure I'm going to be careful to say them right. So if you're having them do autogenic, the opposite, have the other side firing, okay, and then switch for the reciprocal. Does that make sense? Okay. You guys want to try those? Okay, let's try a few QL stretches. Try and think about.
Oh, yeah.
All right, so Williams and McKenzie protocols. There are 2 different approaches to dealing with back pain. depending on the situation the patient has, and we'll talk about those situations where these are more effective at different times here in just a second. But basically what you need to know in general is that Williams is a flexion protocol, and McKenzie in general is an extension protocol. Okay, so just with what we already know this morning and not going into any of our other diagnoses, when would you do which? Right. So if you have an anterior pelvic tilt, you're going to do Williams. Okay? So we're strengthening the abdominals and the flexors. Okay? If they have more of a posterior pelvic tilt, we're going to do McKenzie. We're going to look at a few other options here in just a second. All right. So let's just look at these real quick, and then we'll... Why is it not? Oh, control. So Williams flexion exercises, these are going to look pretty familiar. Okay. So you've got the pelvic tilts, okay, basically that we were doing, or just the draw ins. It's the same concept. To draw in, you're going to tilt that pelvic back. So that's where you pelvis back, so that's where you start it. Then you just have simple sit-ups, okay? So we're strengthening the rectus femoris and even the abdominals there. And then just single knee raises to the chest, then seated reaching to the toes, okay? Then you can add these forward, these are basically lunges, okay, but they call them crouches. Then you have seated flexors, where they're putting their hands, okay, and you roll through. So just let's...
Is that from the book or from the... What do you-
No, this is from our notes, and it's literally... I'll go back.
It's a link. Okay.
Literally a link built into your notes, okay? They are in the Canvas notes, but I just actually like these websites a little bit better because they're easier to see and work with, okay? So basically, Williams, you're dealing with the abdominals, okay? So we want to do that with, obviously, like we said, anterior pelvic tilt, but there are some other important ones. There is spondylosis. Anybody know what this is? If you don't, it's okay. I don't expect you to yet. We're just getting into this.
Vertebrae where it becomes porous.
It can be porous. It's basically just arthritis of the vertebrae. The vertebrae and the joints in the vertebrae start to break down. Maybe because they're porous. Maybe because it's just old age. There's lots of different options for what can cause it. But if they're having that breakdown, flexion tends to work better for them. Okay, and we'll talk a little bit more about this in just a second. This is where these words are going to get kind of weird. Another one is spondylo. Spondylolysis and spondylolisthesis. If I remember how to spell those properly. So these are two that are kind of tied together. This is where it starts and it progresses to this. Okay? Let me pull up some pictures real quick. And it's actually not spondylo, it's spondilo, just so you know. I still say spondylo because I like it better. The other one doesn't feel good in my mouth. But just the proper way. Let's see if we can pull up some images here of what spondylolisthesis is. And I do have a link, but I just wanted to kind of pull up the images. Oh, this is good because it has. Okay, so, and this isn't a part you really learned, but it's the pars interarticularis. Okay, basically, it's this little interaction right here, just before the spinous processes. Okay, so what happens with spondylolysis is spondylolysis. See, it's awful, right? You get a stress fracture here, either from athletes. You'll see this actually a lot in people who do a lot of extension and overextension. Gymnasts. Yeah, gymnastics, you'll see this actually a lot. And it can become a really serious problem. Or as people get older and gravity just starts to pull, then you'll see this fracture. Well, if it's just a simple fracture, or obviously trauma can cause it too, if you rest and give it time, it'll heal. If you don't, then this literally breaks off and starts to float, and this vertebrae will just pull forward. Okay? So if you think about it, and let's kind of draw in here. We've got our spinal column that goes right in through here, okay? If this starts pulling forward, what's that going to do to the spinal column? It's going to pinch it and cause pressure on it. Now, let's think about, so if I try and I've got somebody who has spondylolisthesis or spondylolysis, and I try and have them extend, what's that going to do? It's going to actually push these forward even more and break that off and move them into this. Or it's going to push this even more forward and put even more pressure on the spine. You can literally cause stripping of the fibers of the spine, which can cause real issues, obviously. So, for these conditions, Williams is the way to do it, because if we flex it, what happens actually? It does the opposite. It actually pushes this all back. Okay? So it can kind of help strengthen those muscles to help keep the spine in proper alignment if they do flexion. We cannot, however, have them do extension because we can literally damage their spinal cord and column. Okay? So these are important and to understand that.
Is spondylolysis something they're going to know they have?
Most times, yes. Most times, yes. Usually they'll, and that's where, the PT will come in, but we're about to introduce some other concepts that are really important, okay? Peripheralization. And centralization. And this marker's going to give out. Okay, so when people have nerves that are pinched in their spinal column, either on the edges or in the central spinal column itself, especially if it's in the lumbar region, what kind of symptoms do they get? Numbness, tingling, neurological, neuropathic pain, right? So numbness, tingling, pins and needles that extend, start here and then sometimes will extend down and sometimes will just be down. Like they'll just have these weird phantom pains even down here or in the back of their calf or along the side of their leg. Sometimes even all the way down into the feet. Okay? they're kind of like fibromyalgia symptoms, except with fibromyalgia symptoms, they can happen anywhere in the body, all over the place. These tend to only be on one side, but not always. But you'll just have, they'll be like, man, my butt hurts from here, and then it just runs all the way down, and it's just this burning down my leg. Okay? So, what happens is if what we're doing is helping them, that pain will start to slowly travel back up. Okay? So they may come to you and say, man, it really hurts, kind of starts here, goes all the way down to here and hurts down here. And so if you're working with somebody and you're doing some exercises with them and you're doing Williams, and they go, you know what? It's starting to kind of hurt more here. That's actually a really good sign because the pain is starting to go back up to the actual source of the problem. That's called centralization. Okay? Now the opposite of that, and something we really have to be aware of, is peripheralization, because if we're working with somebody, we're doing abdominal exercises with them, and they're having back pain, and we start doing Williams flexion exercises with them, and they're like, you know what? That pain which used to be right here is now all the way down here. We're making the problem worse. Okay? We're compressing those nerves and pinching them even more for whatever reason. So maybe it is that they do have a spondylolysis and we didn't know it or something like that. We don't always, unfortunately, one of the limits of PT is we can't always see what's going on in their body. Or maybe they really do have this going on, okay? And so we were doing some McKenzie with them. Oh no, wrong, backward Williams with them, but they also have a herniated nucleus pulposus, an HNP, that's going on too, and so we start going the other direction and it causes pressure and tension, okay? That's where you stop what you're doing, report to your PT, and the PT sends them back to a specialist to figure out what's going on. Okay, so just understand these concepts and these terms. Peripheralization means it's getting worse, traveling further down, getting more peripheral. Centralization means it's moving up towards the back. That's a good sign. It'll actually even, and what's weird is some patients will go, well, my back hurts worse than it did. And you're like, I know, but you need to kind of prepare them for that and actually explain that that's what you want. And that's a good thing. The other thing you can see happen that you don't ever want to happen is you don't ever want the pain to just flat out stop. Okay? Because if the pain stops completely, it means you've so pinched those nerves that they're not even getting any signals anymore. Okay? So that's really, really, really bad. If you're working with somebody who has pain that was down in the knee and they're like, wow, it's gone, stop what you're doing. Okay? Immediately report it to your PT. Make sure they get back to a specialist because there's something else going on there. And it's causing a complete pinch. Make sense? Okay. So, the other protocol. So, we do flexion with anterior pelvic tilt and with spondylolysis and spondylolysis and spondylolisthesis. Okay? That's when we're doing Williams McKenzie. Okay? We want to do with posterior pelvic tilt, which we already talked about, with herniated discs. And we'll talk about why here in a second. And with something called ankylosing spondylitis. Okay, so what's going on with a herniated disc We can. I'll pull up the actual image from the book.
That's it forever.
Yeah.
You know the name there.
Brent, you know how.
What? Yeah, but I wanted to.
That's not good.
Okay. So. All right. So herniated discs. There are different versions of them, and they can be different places. But there's different versions, and you guys will kind of learn them. Okay, and these are things you do need to know. But we have the A where it's just starting to kind of break through the nucleus pulposus there and hasn't completely exited the annulus fibrosus, right? You guys remember those terms from 116 and on? So you see in A that nucleus pulposus is starting to kind of exit. It's causing just a little bit of bulge up there, and because of where the spinal cord runs, right behind it, it can start to kind of put pressure on it. Does that make sense? Usually they're here. Sometimes they can be actually out of the front of the disc too, but usually this is where it happens. Okay. The second kind is where it has started to migrate and push even further, but hasn't completely broken through. Then we have where it's completely left and gone out, and then you even can get it to where part of that nucleus pulposus in this final one has broken loose and is causing pressure itself on the spinal cord itself. Does that make sense? So the further it gets, the worse it gets. So this is where McKenzie and extension comes in. So kind of gather around up here for a second. Let me grab real quick. Never mind, I don't have my keys to that thing with me. So just gather around up here real quick so you can kind of see. So when we have a herniated disc, okay, if we put somebody into further flexion, what it does is it actually creates space between the vertebrae, right? So if you think about that flexion, it actually pulls those vertebrae apart like this, okay? So it is going to pinch the spinous processes together, but the body of the vertebrae are actually going to go further apart. And so what happens in that is we actually create a vacuum in that herniated nucleus pulposus, okay? And it actually causes that to suck back into where it's supposed to go. Okay, so you can literally, just by pulling those apart and having them do those extension exercises, create a vacuum in there that will help bring that down. It takes time, like weeks to months, but it can pull everything back into where it goes. You guys will learn in 250 next semester how to use traction tables. That's exactly what traction does too. It just takes the whole spine and pulls all of it apart, okay, and creates that same vacuum. But we have the ability, just through exercises and stretches, to do the same thing. So if a person's not too far along, if they're an A or a B, possibly maybe even a C, McKenzie works pretty well. If they're C, D, then that's when they need a little bit further help, possibly surgical intervention or definitely traction. Okay. So anyways, does that make sense of how and why that works? Okay. So it just separates these bodies, creates space. You create an emptiness. Nature abhors a vacuum. It's going to naturally try and fill it in. Okay. So you create empty space in between these, and the fluid goes back to where it was meant to be to start with. Okay. Ankylosing spondylitis, the ligaments here start to get hard, and then the joints themselves will actually start to grow together. So if we can create space between the bodies, it will actually break that stuff loose and loosen those ligaments. It's an autoimmune deficiency, autoimmune disease, where the body kind of is almost attacking itself again. Okay. So anyways, but if we have them do extension in those cases, it helps separate and bring it apart too. Okay? So know which of these to do at which times, which goes with which. Okay? It's important not just for tests, but for real life. Because you get somebody in who has a spondylosis or spondylolisthesis, and you start doing flexion stuff with them, you're going to hurt them. I mean, you start doing extension stuff with them, and you're going to hurt them. Okay? So this is actually really, really important information. So let's pull up real quick what McKenzie looks like. You guys can sit back there. I just wanted to make sure you kind of have a vision.
Yeah. In the coupons too. Yeah.
Sometimes, no.
Hey Brent, are you done with Jake?
I am done with Jake. I'm sorry. So McKenzie is basically almost the opposite in some sense of Williams. Although later stages of McKenzie, you want to strengthen everything, so just kind of be aware of that. Why is it? Don't want to check. So the very first, and you'll get people that are so forward in pain. Okay, you're to your side, so you're it. So you'll get people who've slipped a disc or who have just back pain and they're walking around like this, okay, and you've seen them. Obviously, their hip flexors are going to get really tight, okay. Their hamstrings will be weak and lengthened, but they're really bent over in pain. So the first step is to try and get them to where they'll lie face down. Just be aware that they may not even be able to handle this to start with. But if you think about it, that's just causing those bodies to even pinch more down on each other. And it's funny that, they're in pain, they don't want to fire their back, they start leaning forward and the problem actually gets worse. And they get in that pain cycle. Then they lean even more forward. It causes actually more pain, and things get ugly. So I'm going to grab a couple pillows real quick. So, they may not be able. The first goal is to just have them lie down, face down as much as they can. You might try and get it for 5 minutes, maybe 10 minutes. They won't be able to tolerate it for very long, okay? If they can't even just lay down, you can put a pillow or two down under that area. Come on, work. So you can do it this way. I tend to kind of maybe like to do it actually this way. Get a little bit of the pelvis, so I just want you to kind of lay down.
Stomach.
Yep. And just lay down on their stomach. Obviously, I would maybe want a pillow for his head as well, if they can handle it. If not, obviously the space. So as they get more tolerant, you take a pillow out, you take a pillow out, get them to where they're laying flat. At least we're creating a little bit of space now between those. Then, all right, we'll fold those out.
Quick progression.
It's a progression. Yep. We progress to just laying. Okay, if they can tolerate that. Then prone on elbows is what this is called. So we have them here, and we just go, you know what? I want you to try and hold this position as long as you can. They may only be able to hold it for 30, 40, 50 seconds, a minute. Relax. Have them go back down, and then have them do it again. Okay? Then we move up from there to where they're doing it on their hands. Okay, so come up onto your hands and extend. So if you start to have anything running down your legs, definitely let me know. Okay. Right. Then final stages are just having them do it standing. So get up, okay, and just have them try and do it in standing. This is a progression because now they're actually having gravity pull on them too, and they're actually even getting a little bit of a stretch that's going along with this too. Okay. Then, if they get to where they're doing this, we actually move in with Mackenzie to actually strengthening abdomen too. Okay? Because Mackenzie's actually a whole back protocol, but it starts with understanding that we've got like these situations going on. We want to separate those discs, we want to get the pain down, then we want to strengthen the whole core. Okay? But really, these first 3 or 4 stages are what Mackenzie's all about. Mackenzie's about extension, Williams is about flexion. Because really after this, you're just moving into Williams type exercises. Okay, does that make sense? Alright, so break up, partner up again, and we'll just walk through these. Okay, I'll pull up Williams again, walk through those with each other, and then we'll walk through Mackenzie together. Ergonomics and body mechanics and things like that. You know, whether they were lifting improperly, a lot of times that's what you'll find it is, or bad ergonomics at a desk or something like that. Alright. Moving on. Alright, so who has their cell phone? Okay, look up for me. Little Caesars. I owe you guys pizza, right?
Oh, Caesars.
That's all you get. If you don't want it, you don't have to have it. And we can order like, what kind does everybody like the most? Mostly pepperoni? We're just looking at like one topping just right. You don't have to eat it. I'm doing the $5 single topping, 4 of them, $20 for all of them. Work? Alright. So, or at least I know. So, what do we want? All pepperonis? 1 pepperoni, 1 hamburger, 1 sausage? So 2 pepperonis, a hamburger, a sausage? Okay. Would you